Got it, Kathy?
Yep. Good afternoon, folks, and welcome to the Maryland chapter of HFMA's webinar on protecting your practice from CMS and DOJ audits. Couple announcements first before we get started. Webinar attendees are all in listen only and view only mode. They will not be able to share their screen or speak. However, we do invite you to ask questions through the Q&A feature on your screen, and we will be monitoring those and make sure that our speaker is aware when they're asked and she will respond. Some other quick announcements. On April 23rd from 11 to 1, we will have the Bill Mooney new member welcome and speed mentoring event, and that is on a Friday, April 23rd. Look forward to having all new members and any folks interested in that speed mentoring event attend. Also, we will be having our first in-person event. Our fall conference will be held at Rocky Gap on September 29th through October 1st. So bearing any changes, we are planning for it to be in person at Rocky Gap. However, we are also having a plan B in case that's needed, but we're hoping that we can see all of everyone in person, and we really are looking forward to that. Without any other announcements, I think that's it. I'd like to then introduce our speaker. Our speaker today is Joette Derricks. Joette and I have worked together over the years, and I can just tell you she is a great mentor and a wealth of experience in the physician world. So we are extremely pleased to have her present today. She's a senior consultant now at Granite GRC Consulting, and she brings with us more than 35 years of experience working with healthcare organizations and really providing some great practice management expertise. She has served as a qualified expert witness, and she's given testimony and provided expert reports for national healthcare clients. Through her educational background and her years of working with organizations, she really brings broad experience in strategic and organizational performance measurement, business reengineering, process and procedure development, and revenue growth initiatives. She's a nationally recognized leader in this field, and she has been invited to speak at numerous events, including the National AAPC HealthCon Conference, the AHIMA National Conference, the MGMA National Conference, and also speaks for the Healthcare Compliance Association, which is one of the reasons we really are looking forward to her talk today. She has her Master's of Public Administration from Penn State. She's a fellow for the American College of Healthcare Executives, a CPC. She's also certified in healthcare compliance, and she has a certification in Six Sigma Green Belt, and has a Green Belt in Lean and Six Sigma. So we are really excited to have Joette share her information and knowledge with us today. So without further ado, I will hand it over to Joette.
Okay, thank you so much. It's a pleasure to be here. I am going to share my screen, hopefully in a minute here. Do we have my screen up?
We're not yet.
Quite yet.
Not quite yet. So let's see. The host disabled participant screen share. Okay. So if I go to share screen, why am my screen not coming up? Oh no. Technical difficulties out of the starting gate.
Hey, Holly, I believe if you go into your settings screen, you can allow participant screen sharing, and I hope Joette would be able to share her screen after that. I think that's one of the blockages.
Yeah, it's coming up as a message saying host disabled participant screen sharing. So I think you have to hand it off to me so I can share
Right.
my screen. Yes. Is Holly still with us?
Holly's still with us?
I am. Can
great.
you?
Thank
Okay.
you.
Sorry about this, folks. All right. Well,
Can you do it now?
disabled. Okay, let's see. Share screen. Let's see if we can get it up now and get running. All right, folks.
There you go.
Let's go to the slideshow and start. Okay, everyone, I am honored to be here, and thank you, Kathy, for that very nice introduction. And also, thank you, Maryland HFMA. It's interesting, I remember my first Maryland new HFMA member meeting years and years ago, and it's just a fantastic organization, and I'm glad to be part of it. So in this, I want to say we're protecting your practice from CMS and DOJ audits. This initial screen, I had a couple of different graphics that I was originally going to use for this other than the elephant in the room. And when I realized I was talking to a bunch of financial people primarily, I often feel that compliance and compliance related is kind of the subject that they're not as comfortable with. So hopefully by the time we wrap things up today, everyone will be comfortable with the idea of compliance and how you can best protect your medical practices from CMS and DOJ audits. So without further ado, let me get right into the material because I have a lot of things I'd love to share with you here today. And so let's just start with some facts. Really, in fiscal year 2019 was significant because it marked the 10th consecutive year that settlements and judgments in healthcare fraud had exceeded $2 billion, that's B with a billion, dollars in paybacks. And an interesting thing with that is that over almost 75% of it was from whistleblower suits. So we hear about a lot of these. We hear about the big blockbuster suits in the media. We hear about them in our professional journals, and we see that a lot of them have been the pharmaceutical companies recently, medical device, long-term care, and hospitals. But one fact I absolutely want to share with you is that small practices and physician clinics are not exempt. We see a number of suits, a number of false claims action in the small practice setting and in the medical group setting. In the last year, we had one group that paid back $5 million for allegations that they reported invalid diagnosis coding. And that was in regard to Medicare Advantage plans. We had another medical group that paid back $6.7 million for billing unnecessary eye exams and for improperly waiving copays. So 2019 was kind of a blockbuster year, that 10 years that exceeded over $2 billion in paybacks in the fraud area for healthcare. 2020 was not as active. We know 2020 was an unusual year in a lot of other ways. But it did not stop the Department of Justice from entering into some new false claims action matters. There was about 900 and some new cases. Most of them were in the hospital and physician arena. And again, 2/3 of them, I'm sorry, 3/4 of them were filed by either current or ex-employees. So here's another fact for you. It is extremely important that you listen to your employees. I'm not saying you have to agree with them, but if your employee brings a concern about your coding or your billing to your attention, you need to take that concern seriously and you need to investigate it and find out, is there some substance behind it that you have to, should take corrective action in. And having your HR looped into your compliance program is definitely a key point in determining whether you have an effective and a robust compliance program. And those are two key words there, robust and effective. And we're going to be talking about what makes your compliance program effective throughout our program here today, throughout this. So some other facts I want to share with you is that even as recent as December of 2020, the Deputy Assistant Attorney General indicated in a speech before the American Bar Association that even though they've had this wonderful success in terms of false claims actions that have taken place due to whistleblower claims, that isn't where they want to focus going forward. Their goal going forward is to incorporate sophisticated analysis of Medicare data to uncover potential fraud schemes. So they want to say that, yes, we get a lot of information, we get a lot of tips through whistleblowers, a lot of things to look at, but we're going to expand our reliance on data analysis. We think that there is a lot that we can find that may be fraud and abuse by looking at the numbers. So I think that's right up the alley of people in the Healthcare Financial Management Association. We all know that your information, your numbers, your key performance indicators hold a lot of information that can serve as warning signs that you may have a problem. For example, as simple as monitoring quarter-to-quarter performance of your volume of certain services, like your E&M services. Why in the second quarter did our reporting of 99214 CPT code for a level 4 office visit, why did it increase by 30% in the second quarter over what we billed out in the first quarter? That should raise a question. And if an employee comes to you and says, why are we doing more 99214 this quarter than last quarter, or this year than last year? It's something that should be investigated and looked at to make sure that those are being billed correctly based on the regulations and the guidance for how to support billing E&M services. Now, just as an aside, we know that office visit, the E&M service regulations changed in 2021. And so it's caused a lot of confusion because many people think that those new regulations apply across the board to all E&M services. And so we have one set of guidelines for office visits and outpatient services, and we have a different set of guidelines for all of your other E&M services. Still, the point is, get to know your information, know your own numbers, analyze them, and look for the outliers and the deviance and patterns that may cause some concerns. So let's talk about a different area that I want to share with you, and that's to talk about HIPAA here for a minute. HIPAA was passed in 1996, and we often think of it as the privacy and security regulation, even though the P in HIPAA does not stand for privacy, it stands for portability, but that's a different session. So let me ask you guys, what does the A, the first A in HIPAA stand for? Anybody know? Okay, well, let me just tell you, the first A in HIPAA is for accountability. And I bring this up for several reasons because under the HIPAA law, many people do not realize that when HIPAA was passed in 1996, it gave CMS additional scrutiny, additional techniques to help them an ability to develop and prevent fraud, to detect and prevent fraud. In fact, HIPAA in 1996, the accountability sections put into place the Medicare Integrity Program, the MIPS program, the Medicare Integrity Program was started at that point in time. So but let's talk about HIPAA from the security and privacy aspect. Now, HIPAA is not a CMS program. although we do see the different branches of Health and Human Service interplay here, the Office of National Coordinator for High Tech and the Office of Civil Rights, which are both under HHS, run the HIPAA privacy and security. And they have released a comprehensive assessment tools. And I will tell you, as a warning sign, if you have not conducted your assessments and updated your assessments on an annual basis, it's likely you have compliance issues in this area. So it's really key to look at that. And we're going to talk about the CMS accountability piece in a couple of minutes. But one of the things that we're also seeing as a trend tied into HIPAA is the increase in outsourcing. And we're seeing outsourcing. I was really surprised. I read an article just recently that it is projected that for physician practices that in the next 5 years, 90% of them are going to be outsourcing their coding or billing or some portion of their revenue cycle management. And I was astonished by that. I thought, wow, I knew that we were seeing a high level of outsourcing with other provider types, but I was really surprised to see that in the terms of projections on the physician side. Now, and there's also a tendency with outsourcing on the clinical side. And telemedicine is bringing a lot of this to the forefront, and we're going to be talking about telemedicine specifically in a couple of minutes. But what we're seeing is that in this global world we have technology that's feasible from a clinical side to do diagnostic testing services, remote office visits, even remote surgical services, both within the United States and in other countries. And we've often had hospitals have had these kind of like Nighthawk programs where X-rays or TC scans are being read in a different country in off hours. And those are fine if they are being billed appropriately, because under the Social Security Act and under the Medicare billing rules, payment for non-emergency services rendered outside the United States is prohibited. So what we often see is confusion of what number or an MPI number of which services are being billed under. So for clinical services, it's especially important to ensure that if they're being done or any portion of it is being done overseas, that there's a clear understanding of the federal healthcare rules, regulations impacting that, along with the whole HIPAA aspect. Now, in addition to this concerns, and I could tell a lot of stories of different assessments we've done of outsourcing companies from coding, where we find that we have yet to find that an offshore coding or even an in-house, in the United States outsourcing coding company has been able to meet the same level of accuracy that in-house coders have. And I find that really interesting because the tendency is that, you're going to save money on outsourcing. And I'm not too sure, especially, I find it interesting in talking to financial people that the numbers have not really proved out that in the long run, it really is the cost savings that perhaps the vendors are selling. So this is, the regulatory and legal requirements beyond HIPAA, including your state rules, regulations, how to bill auto, how to bill, workers' comp. We often find on the coding side that national guidelines are being supplied. And those national guidelines don't necessarily represent what is happening with your MAC, your Medicare administrator, or with even other payers. Like, for example, Anthem has their own set of guidelines for E&M that are more stringent than the standard AMA CPT guidelines for E&M codes. So you need to take a look when you're doing this. And it all starts with a good contract, evaluating the risk. If you're going to outsource in any fashion, It's that trust but verify everything that is being done. And you need to not just do it once, just like your HIPAA risk assessment is not a once and done. Any type of monitoring and auditing is an ongoing aspect. Monitoring is ongoing. Auditing is more when you bring that external firm in and you ask them to take a look at what is going on. So let's go back to CMS in terms of what they are specifically doing. Kathy mentioned that I've been in the healthcare arena for a number of years, and I got my start working for what is now one of the Medicare administrator contractors. And I ran actually one of their Medicare programs that they were administering, and then was in provider relations for them. And back then when I first started, in order to get a copy of an LCD, a local coverage guideline, you had to file a Freedom of Information request. And that's one of the reasons how I got into consulting with physician practices, because I would go to what we didn't really use the term compliance per se back then, as much as utilization review. And we would go to these quarterly utilization review meetings, and we would have doctors that were on the kind of the firing squad of trying to defend their coding and billing for certain services. And I would sit in those meetings and I would think, gosh, this is amazing. We're asking them to pay back $20,000 or $200,000 or whatever it may be dollars for inappropriate billing. But I don't think we ever told them what the rules and regulations were. Now, so much of what CMS does is open to us. We have the information out there to make a decision. And what we have found is that practices need to use the resources that are available to them. So we have the CMS is doing audits. We have the recovery audit contractors. All kinds of audit programs are out there. Now, I want to though talk about how these can help you to defend the practice going forward. Targeted probe and education program. Tell me, how many of you have had a TPE? Do we have anybody on the webinar today that have had their TPE? Okay. What we have found is that the targeted probe and education program, a lot of practices have not taken it seriously because it can be a post-pay audit, but it's normally a pre-pay review. And you go through you get three tries to get to the right accuracy rate. And since it's prepaid and there's this supposedly education component to it, a lot of practices kind of poo-poo it and don't take it seriously. The problem is that by the third review, if you still haven't reached the correct accuracy rate that the payer is looking for, that Novitas in this case is looking for, they can flip you over to a total 100% prepay. They can come in, send you through the OIG. They can start doing extrapolations. It can become a real mess. So another program that is an early warning sign, and on the hospital side, we have HIPAA reports, but on the physician side, it's comparative billing reports. And again, these are kind of a way for physicians to know what is being looked at, what is being analyzed, and how can I use that information. So here is from a clip of just part of what is out on Novitas regarding audits that they have ongoing. So they're telling us we're auditing cataract extraction. If you're performing cataract extractions, then you should take a look at those codes in line with those guidelines. If you're providing psychotherapy services. So nowadays, I have found that CMS is much more open in sharing regulations and in sharing what they are looking at going forward. And it gives practices an opportunity to take some defensive posturing to protect their practice by looking at those things before it develops into a problem in which maybe the feds will be coming in. This particular slide is one of the comparative reports specific to billing the annual wellness visit, welcome to Medicare visits. And if you look here in the Maryland for the G0439 state average, that's the subsequent annual wellness visit. It's saying that the state average is that 49% of the time in Maryland, that code, the G0439, is being reported in conjunction with an E&M code. Now, to me, there's several red flags here, several flashing yellow lights. One, E&M modifier 25 is one of the most misused and misunderstood modifiers out there. And if you're going to use it, you have to understand what a significantly separately billable E&M service is. What does that mean and what is different? You can't double dip what you're doing for the subsequent annual wellness visit and count something for both that and both the E&M. So it's, again, an early warning sign that this is something that the government is taking serious and thinks there could be fraud and abuse. Another aspect of how you use this information to help protect your practice is, okay, if 49%, 48.71% is the state average, are using the G0439 in conjunction with an E&M, if you look at your numbers and you're at 80% or 85% that the time you're reporting the G0349 code with an E&M code, what are you? You're an outlier. And anytime you're an outlier, you're up for review and investigation. Basically, a lot of the statistical information is if you're 2 standard deviations out from the norm, you are definitely going to get audited. So this gives you, again, a way to take a look at what is the government looking at? How can I use the information as my early warning signs, do my own internal analysis, or, and through my compliance department to ensure that I can make sure that we're doing it correctly on our side. So one more here in terms of where you can get some early warning signs is our OIG. Now, the Office of Inspector General issues a work plan, and they used to issue the work plan annually, and now they update it continuously. So when I checked a couple of days ago, there was 280 active OIG work plans out there in, for healthcare billing. And these are just 4 that I picked out of there, that of the 280, there's 27 that are specific to physician services. Now, that doesn't mean those are the only ones that apply to physician, because like they have a separate category for telemedicine, and we're going to be talking about those in a minute. But these 4 are all ones that I've had expert cases on in the past few years. So if you're providing sleep disorder, if you're a sleep disorder clinic, then you got to know what is happening, what are their concerns there, are you billing those services correctly? Same thing with the physician billing for critical care evaluation and management. They're also looking at transitional care management services, chronic care management services. They're all out there on the OIG work plan. Let's talk for a minute about the advanced care services. I love that CPT and Medicare recognize that advanced care planning is a very worthwhile service to provide to Medicare beneficiaries, and the CPT code 99497. Now, it is really helps, the objective is to help individuals make decisions about their care, important decisions about, the control over the type of care they may receive, especially towards the end of their life. They don't have to be on hospice or anything like this to get the service. It can actually happen at any time in their life, but there are certain requirements for this service. Does anybody know the two key concerns? What do you think the two key concerns that OIG may have regarding this service? And if you got an idea, put it in the question and answer field here. And what are the two key things that OIG is going to be looking at in their audits for advanced care planning? Any ideas? Yeah, okay. Well, the two key things are that they have found, based on previous studies, that there's a lack of clinical documentation. Now, lack of clinical documentation is one of the #1 reasons why people get audited and why physicians get audited and why they end up paying money back. In this case, there's two key pieces of information that need to be in the clinical documentation. The first is that it has to document that this was a face-to-face service. The second is it has to document the time. Anytime there is a time-based code, this code is for 30 minutes, first 30 minutes. Anytime you see a CPT code or a HIPAA code that has time associated with it, then time must be documented in the medical record. And again, here is their checklist to say, look, take a look at your services, make sure you're doing these things, make sure you're documenting it has a valid, there's been a real concern about valid and legible signatures, whether it's an electronic signature or not, that it's valid, that it's a face-to-face voluntary service. So you want to make sure, and of course, this particular code, even though it's the first 30 minutes, it follows the CPT guidelines that you can bill it once you've exceeded the halfway point, which is the documentation has to support at least 16 minutes. And I'm just going to, again, a little segue here, because I recently was involved in a very comprehensive, a lot of behavioral health work, auditing, and found it very, very interesting. There again, the services are time-based, and found it was very interesting that everything met just exactly the halfway point. Again, maybe every discussion with their patients did just take 16 minutes, but you really don't want to default to a time necessarily as a pattern. Although back to EMRs and poor templates, your advanced care planning template should not let you close that without some documentation of time. But don't just automatically drop in 16 minutes every single time, because that's, again, becomes very suspect. Okay, so let's get to the big three. The big three that we said we would talk about. In 2020, the Department of Justice said, these are our priorities. And they have said, these will be our priorities for 2021 also. We're going to continue to look at these things. And man, are they doing it. They are hitting these three areas at an impact that is very surprising, especially since with telemedicine and COVID-19, we didn't even know of COVID-19 before 2020. So we've had this very unusual year where a lot of things were messed up, and it doesn't matter. CMS, OIG, and even other payers, they're going to follow the money. And if you got paid or are getting paid in these areas, it is critical that you know what the guidelines are and you set up the right processes and procedures to protect your practice from these potential audits coming down and potential paybacks. So let's break each of these down. Let's talk about the opioid problem. We know that there's an opioid problem. Everyone in the United States that listens to the news knows about it. Purdue Pharma is in the news constantly. There's been major paybacks. In 2017, our president at the time declared the opioid crisis a public health emergency. Way before the COVID emergency, this was a national health emergency. And it hasn't gotten any better, really, in some respects. In 2017, the OIG identified about 70,000 Medicare Part D beneficiaries who were being prescribed opioids in quantities that suggested serious risk or misuse of the amount of dosage that they were receiving. In 2018, they looked at those same beneficiaries, and they found that 11% of those that they had identified the year before did actually have an overdose. So what their concern is if we being the Fed saying, if federal dollars is going to pay for Medicare Part D prescriptions in this area, we want to make sure that those prescriptions are appropriate, are at the proper utilization, and that people are getting the care they need through those prescriptions. Now in 2020, the OIG looked again, and they found that there was, just in the first 8 months of 2020, over 5,000 Medicare Part D overdoses. And again, about 220, the number went up significantly. And perhaps it's through better, again, analysis, better record keeping, but they found 220,000 Medicare patients were getting prescribed at higher dosages than the recommended dosage in opioid. So the government said, this is a problem. We need to address it. So CMS came out with guidelines. They set up a new, basically a new type of provider, an opioid treatment provider program. And they started to look at these, what was required. And we had in September of 2020, we had the largest takedown from the FBI that we have ever had, a historical national takedown, that they arrested 345 people across the US, primarily related to opioids and telemedicine abuse. And we're going to get to telemedicine in a minute. But really concerned through, as I said, the Medicare program integrity, that there was significant abuse in this area. Now, of those 345, you may again say, okay, it's big pharma, it's these, real scams going on. Yes, some of that was, but remember, small practices and small clinics, physician clinics, are not exempt. There was more than 100 doctors who were caught. About 1/3 of those that were rounded up in this takedown were physicians or other licensed medical professionals. So let's talk about, what you can do about it. I mean, the message should be clear here, is that any individual or any company that's in the opioid supply chain, you're subject to CMS and DOJ scrutiny over this. Now, in turn, in December of 2020, we had the Center of CMS put out, as I said, an update to the opioid treatment program. They put out some new billing guidelines on how to handle this. And this is a Part B payment can be made through for the opioid treatment services. And there's new G codes out there. And this is often overlooked, that people look to the CPT codes and they forget that even though there could be a CPT code that describes the service, if Medicare has said, nope, hold on, we want you to use this G code instead, then that's what you need to report. So these are time-based services that were effective January 1st of 2021. Like, for example, G2086 is office-based treatment for a substance use disorder, including the treatment plan, the care coordination, individual therapy, and group therapy and counseling, at least 70 minutes in the first calendar month. So you build a service, you got to track it, You got to track, okay, when did we do counseling? When did we write the treatment plan? And you have to make sure, again, that your process is set up to meet that type of requirements that they're putting in to look at everything. So there is very specific now guidelines on the coding and billing for these new opioid codes and for what is going on. And you can find those whether you're a part of the OTP physician, or even if you're a primary care physician and using some of these new services, you can find those new codes on the CMS website. You can also find the updated diagnosis codes, which they looked at the category, ICD-10 category of F11 is opioid related diagnosis. And they have put out some very specific opinions. Guidance is the word I want to use on how to code for those and what kind of behavioral patterns trump another behavioral pattern. So for example, if in the note it says use and abuse, then that equals abuse. If it says use, abuse, and dependence, then you're deferring to the dependence. So there's kind of a hierarchy there that they established in these areas. Now, I mentioned the Purdue Pharma, the Oxycontin paybacks that we hear about. And we have many others, but don't forget that these are also hitting our small practices. So if you are doing anything within this area, I caution you to take a look at it. Make sure that your billing rules and regulations are in line with what CMS and DOJ are looking for. Let's move on to telehealth. We still got a number of things to cover here. Telehealth, we have, again, the big scams going on, where people are sitting in India or the Philippines or something and finding physicians' numbers and names and filling out false prescriptions for, durable medical equipment and things. But where we're seeing the real concern in telehealth, the OIG has put out 7 different work plans specific to telehealth. And where we're seeing the real concern is in the physician practices in particular, where you tried your best in 2020. You perhaps maybe weren't doing telehealth before that, but in 2020 with COVID, you tried your best to continue to provide good patient care to your patients, but all of the rules and regulations, CMS, there was, changes constantly. One day it was bill it this way, a week later it was bill it that way. And we had state guidelines coming in, and we had payer guidelines coming in, and quite a mess, very complicated. But regardless of it, they're following the money. And just like even on the private payer side, just as to let you know, 5 of the big commercial payers are currently conducting telemedicine auditing. And the initial results that we've seen from clients and that we've talked to that have been hit with this is the accuracy rate is about 68% that these services were billed correctly. And the 2 big things with telehealth is that you had the technical telehealth requirements, and then you had the service requirement. So what we found is, again, say it was, you were doing psychotherapy, which there was a huge jump in psychotherapy being done through telehealth. And so they maybe documented the telehealth technical requirements, use the right modifier at the time. But then they didn't document everything that they should have documented just routinely for the psychotherapy service. So what we strongly recommend is that you conduct a telemedicine self-assessment review. And the sooner you do this, the better. You need to look at, we started our telemedicine program in this month. What was the guidelines in that month for CMS? And also you want to conclude your other payers. And then this changed, the guideline changed in July, and the guideline changed in October. And you want to lay this all out to make sure that for whatever period of time that you were providing telehealth services, telemedicine services, and getting paid, that you were in compliance with your state regulations, your Medicaid regulations, your private payer regulations. And in particular, when we're talking about OIG audits, we're talking about, the CMS regulations on this. So this is the best time for you to take a look at this. Let me just share with you that this year, 2020, is not the first time that the OIG was concerned about telemedicine. They actually released a report in April of 2018, and they found 31% of the sampled claims that they reviewed did not meet the Medicare conditions for payment for telehealth services. So there was already concerns in this industry prior to the COVID public health emergency that pushed telemedicine to the forefront. And this is part of the reasons I always like the MedPAC report to Congress came out about a month or so ago. It's one of my favorite reports because it has a whole lot of good information in it, and it tells us possibly where Congress and CMS is going to go in the future. And there's been a lot of buzz about let's keep telehealth going, let's keep the public health emergency beyond the public health emergency for telehealth. But MedPAC actually did not recommend doing that because MedPAC said very specifically they are too concerned about the fraud and abuse in this area to continue telemedicine to the extent that it is today. Now, we'll see what that plays out to, but I really recommend that you conduct an investigation now, an assessment, your own self-assessment of what you did with your telehealth claims, and that if you need to do any additional education or training to play for that. So as I said, OIG has these 7 different ones. One was just released the other day, the work plans. Some of them are in home health, but there are several that are very specific to the OIG will analyze Part B providers' billing patterns back to data analysis for telehealth services. So we need to take a careful look at that. There's concerns that was the same level of service and quality delivered that would have been delivered if the service was done in person, since it was done on the telephone. So take a look at those different audit work plans that are out there on the OIG website that I gave you for telehealth specifically. All right, COVID. Oh dear, COVID is one of, has just been its own pandemic for fraud. There's all kinds of schemes and scams going on in the whole COVID world. What OIG is most concerned about right now is the big money, and the big money that they have been giving out with Paycheck Protection Program, the Provider Relief Fund Program, the CARES Act, the Corona Aid Relief and Economic Security Act. They have given healthcare providers a lot of money. And DOJ is saying that they're going to pursue actively fraud-related activities regarding the COVID-19 relief. And they're going to look at this criminally. When we talk about fraud, we have civil cases and we have criminal cases. But they're going to look for criminal prosecution of individuals who made false statements in connection with getting the provider relief funds or the Paycheck Protection Program. Now, again, one of the things, as I said, the government is sharing a lot of information, and I have the link here. They have a COVID-19 portal. They have their fraud alerts out there. They saying, this is what we're looking for. This is what our concerns are. And it is, again, your opportunity to make sure that if you were getting those funds, that you have, have applied for them with correct and accurate information. And that those, and that you're following all of the guidelines regarding those relief funding that you receive. All right. Maybe some of you are a little shocked. Maybe some of you are a little angry or upset. I hope nobody's going to break into tears from what I'm sharing with you today. So let me kind of switch more over into how you protect your practice on these things. The original OIG compliance guidance first started in 1998. From 1998 to 2008, they released guidance programs. They're still available. There is a guidance program for physicians. There's a guidance program for hospitals, for skilled nursing. They are a tool that you should read and use at least annually in your practice to say, wow, I forgot we should be doing this. People have been talking about compliance now since 1996 when HIPAA was passed. And they said, we're going to start coming after you for these things with the Medicare Integrity Program. And it has evolved from, do I have a compliance program, to do I have an effective compliance program? And starting in March of 2017, the HCCA, the Healthcare Compliance Association, which I'm a member of and actively support, along with the OIG, released a document saying, this is how you measure the effectiveness of your compliance program. It's an excellent tool to work through on within your practice setting or any setting in order to know, am I doing the right things in regard to compliance? And then we had along with that, the US Department of Justice released an evaluation first in 2019 and then updated it just recently. And these three questions are key. Is the corporate compliance program well designed? Is the program being applied earnestly and in good faith? In other words, is the program adequately resourced and empowered to function effectively? Wow, that is powerful. And I want to talk to you about what that means, adequately resourced. In my opinion, that means if I come in and I look at your budget and there is not a line item budget for compliance, you do not have an adequately resourced compliance program. If I come in and I look and you do not have any kind of a dedicated, it does not have to be a full-time employee for compliance or part-time employee, just like, let me put it into you this way. I used to say that a practice would not be in existence without legal counsel. Now, your legal counsel generally is not a member of your workforce staff. It's an independent law firm that you're using to give you advice. Many practices use an outside CPA for their financial profit loss taxes. My view is whatever you are budgeting and empowering those functions to protect your practice, you should be resourcing the same amount to your compliance effort. And this is where compliance has always gotten the backseat. People did not see it as really a necessary function to run a practice or to run a hospital or anything. And I'm telling you, it is a very critical factor, the comprehensiveness of it, to ensure that you do not have misconduct in your practice setting, that it's not being tolerated or overlooked. So these assessments are very good as a starting point to know where you stand in terms of protecting your practice against CMS and DOJ audits. So along with that, the old be prepared, it's again, there's a lot of warning signs, there's a lot of information out there, there's a lot of ways for you to evaluate how you are doing within your practice setting. And what we need to do is that to make sure that you have things set up accordingly. Now let's talk, I'll give you 8 steps that I think you should be following to minimize your fraud, waste, and abuse. We've talked about it all throughout here. Install a culture of compliance. Follow the OIG compliance guidance. Number 3, encourage and deliver bad news. This to me is key because I believe that bad news delivered early is good news. But bad news delivered late is very, very bad news. So when that employee comes up and says, gee, why do we have an increase here in billing more of the services? Why are we getting denials here for this code? Why? All of those why questions for monitoring your statistics, your frequency, your billing patterns, your numbers, all of those statistics, when something is identified as a potential outlier, as a potential something has changed, could be good news because it gives you the opportunity to fix it before it's become a cancer on your overall practice. Okay, we talked about, resourcing adequately. My rule of thumb, even I say, what you're paying your outside financial firm, what you're paying your outside legal firm. Look, you have malpractice insurance. You wouldn't be in business without malpractice insurance. Compliance is like your practice, malpractice insurance. So fund it in a robust way. There are opportunities. You do not have to hire your own staff. The OIG in their guidances have been very clear that you can use an outside firm, an outside compliance officer or individual or firm to serve in this role for you. Document, document, and document. Absolutely. We talked about benchmarking, monitoring, auditing. When you are going to do something or have a problem, make sure you know that you got the right resources in there in terms of your consulting advice, legal advice, individuals that have the expertise to guide you on how to best proceed with any kind of a review or investigation. And obviously retain legal counsel earlier in a process than later. All right, I know I'm getting short on time, so the elephant in the room is going to kind of leave a couple of information minutes here for any questions that you may have. You can use the Q&A, raise your hand here. Happy to answer any questions. Do you have any questions?
Give them a moment to type in.
Okay, don't want to be too quick here.
Okay. I'm not seeing any, Joette.
All
Thank
right. Well, I hope I didn't overwhelm anyone, and I hope I didn't offend any of the financial folks in the room that in terms of my concerns that they kind of have in the past diminished the compliance role, but I want to advocate that it's the best thing you can do to protect your practice is to have a robust, effective compliance program.
Thanks, Joette. I really think that your comments were so timely, especially with so many of us having to really quickly put up telemedicine programs and feeling like we were getting by, but now knowing that they're going to start crack down. And I think it's really an important message and really appreciate, it's always, when I hear Joette speak, she always kind of makes me a little nervous for my clients and reminds me that, it is such an important line item. It's such an important, because it only takes one instance and one little thing. You pointed out early in your discussion about listening to your employees. It's so important because it just takes one small little investigation that can really open up a can of worms. And put some practices out of business. So I'm really thrilled that you were able to spend time with us. Thank you so much.
Well, thank you. Thank you for the opportunity. I'd welcome it, and happy to answer any other questions that people can reach out to me. Happy to do that. Thanks.
I do see one question here.
Okay.
Should practices that outsource have a specific section in their compliance plan?
Yes, absolutely. Because I think people don't realize that there is regulatory guidelines that are going to apply, especially if it's offsite. And if you're going overseas, you know, if you're doing coding and billing is going to be done in India or the Philippines or something, you really have to have it addressed. And it starts with that firm contract. Even with shops in the United States that are these revenue cycle management companies, you want your contract to be very firm and very specific to your needs, to your key performance indicators, to what you want with your timelines in that. And, you know, we find that the vendors come in with a set contract and you just say, they say, this is our agreement, sign it. And you need to look at it for what your needs are, and you should definitely have it as part of your compliance program. Absolutely.
Great. Thank you, Joette. Thank you
All
very
right.
much. So couple last minute announcements. Evaluations, very, very, very important to the chapter as we plan these events. We want to hear from you and know that these are timely and that these are the things you want to hear about. And we welcome that. You will all receive an email. And we ask you to please not ignore that email and to send in your evaluation. Also, don't forget, April 23rd from 11 to 1, the Bill Mooney new member welcome and speed mentoring event, and our fall conference in Rocky Gap, September 29th to October 1st. And thank you all so much for attending. We hope to see you soon.